can ask questions, but they won't necessarily be answered. And so we'll start with Corporal Helton. So, Corporal Helton, so I'm going to start by asking you, describe the training that Davis police officers receive, or maybe what we also see in the county, because it's a county-wide training. And specifically, I'm talking about CIT and other training that you receive at Davis PD.
Sure. Well, California Commission on Peace Officers and training also happens in the law enforcement academy section.
Yeah, leaning forward.
Very initial points. We have the CIT training, which is a 40-hour training that takes kind of what we've learned in the academy, the things that we've maybe learned doing the job. Breaks it down for us. We have a in-depth discussion. We have a chance to speak to consumers and people with experience here from them about how their experience with the system and law enforcement affects them. With the idea that it will hopefully hone our intentions, that we're able to deliver better services to our people.
And what about your young officers, training one-on-one?
Field training.
Yeah.
So when you first become a cop, you don't just get released into the wild. That's a good thing. You're partnered with several different senior officers that have been selected to be a trainer. And so during that initial phase of training, the officers already been to the academy. The field training can last 3 to 6 months, depending on the agency. The officer is observed, mentored, given feedback on all parts of the job that includes responding to people in crisis. And so through that process, they get to practice all the different skills that they've hopefully been exposed to and that have been home feedback. So from de-escalation to talking to people in crisis to really being able to negotiate and find out what needs the person has. Involuntary hold or include response model, code responder model, connecting that person with the provider. If you need to go to the hospital, they're in so do that. But that's kind of the last resort. The hope is that code responder model we have in place now. Keep the person engaged in a sort of voluntary receive a service. We go to pay off. Okay. So, next.
Are folks that are remote able to hear? They're able to hear. Okay.
Yes, and they're able to see.
Okay, and remember, like I know you're talking to me, but you're really talking to the voice, big outside voice, or
okay.
outside voice. And you mentioned something just now about the co-responder model, and that was my next question. And I know that's the model we're using in YOLO. Can you describe that a little bit and how it's working in Davis?
So the co-responder model is an idea that law enforcement only has a limited set of skills, but responding to people in crisis, that's just something you can't train everybody to get next week. So to facilitate and improve response and try to get outcomes for except people are engaging voluntarily and they're receiving the services they need. We have a co-responder model where we work with clinicians that are assigned our organization to go out and work together to connect the person who's receiving services with the services they need. If there's not going to be a potential threat to the responder or the public in that co-responder model, law enforcement doesn't have to go. We will only go if we're requested or if there's a threat to the public or a weapon involved, or there would potentially be a threat to the clinician that's going out there. But having the law enforcement pairing with clinicians gives that person access to different connections within the service community that they wouldn't have just with the cop or his phone number.
In your 18 years, have you seen an evolution at Davis PD throughout law enforcement from, sort of the command presence style as opposed to the de-escalation model, especially with this population? Can you talk about that?
Yeah, well, I think command presence has been part of, I guess, the response to some mental health crises in the past, but cops for years have been saying, like, we know that isn't necessarily the best way to respond to things. So when the county implemented the CIT program, was it 5, 8 years ago now? We started getting that training. I think that one improved our response, our ability to de-escalate and take perspective and understand where a consumer's coming from when we show up and get involved in their really, really bad day. And now that we've had clinicians available to co-respond with us, I personally think that is a vastly improved service delivery model. One, I understand that when I show up and I look like this, some people have negative associations with the uniform, with other people that look like me and have done things I've had to do. And if that's the barrier to helping a person have success in dealing with a crisis, then let's find another tool. And that's where the response, I think, shown. We were kind of talking earlier, and there's some people in our community that aren't going to respond super well to me, but I can get Rebecca or Rob connected with them, and that is going to help them so much more than just me showing up. But there is a response, I think, that sometimes requires law enforcement. And sometimes when a person is in crisis and they are doing things that are dangerous, or they're interacting with their environment that is dangerous to other law enforcement. But before we go in, we talk, we plan, and all of that, I think, is going to much improved response to people.
Will you briefly describe the type of calls you get that might require a 50 evaluation? That's a broad range.
So many. I've been to calls where it's someone who wants to kill themselves. I've been to calls where it's someone who's having hallucinations and are acting out and engaged in behavior that is bizarre and disturbing to the public. I've been to calls where people have been in crisis and they've been unsafe, that people are living with unsafe, community members. And all of that sort of falls into, I guess, kind of three groups that we're evaluating for the involuntary hold. And that's someone who's a danger to themselves, someone who's a danger to others, and someone who's someone who's a danger to themselves might have been a UC Davis student that I went to go try to find because they were texting a friend saying they're going to kill themselves. The person called us because they were concerned. I found the person sitting in a car with the noose tied up on the seat next to him, and we went to the hospital. Someone who is a danger to others might be somebody who's they believe that other people are get them actively. So stop the receipt. And so then we have to intervene, keep the community safe, and keep that person from harm to themselves. Community members. Gravely disabled is another class where it's someone who, because of their mental illness, is no longer able to care for their basic needs. There was a lady in a park who, because of her mental illness, refused to leave her tent, and by the time we got there to interact with her, she'd been in the tent, hadn't left, hadn't eaten in days, was covered head to toe with soil everywhere. It was very unhealthy because of that, so we had to take her to the hospital. So those are kind of the span of calls and then sort of the categories that they fall.
I've heard some criticism over the years, and actually some maybe frustration about family members who feel that law enforcement, not necessarily Davis PD, have not found that their loved one has met criteria when the family feels clearly they do. I mean, they're not experts. How do you obtain the necessary information to make that difficult decision? Because, I would think that for some of this population, they might not appear to be gravely disabled. You ask them if they're gonna harm themselves and they say no. You ask them if they're gonna harm others and they say no. How do you gather the necessary information to make the right or the best decision?
Well, the CIT training, I think, supports what I'm about to say here. That kind of opened up as officers our idea that, when we're responding to a potential crisis, we need to do more than just talk to the person who may have experience with the system and know that if they say something a certain way, that they're going to lose their right to make decisions themselves and go somewhere they don't want to. So they respond with, I'm not a danger to myself, I'm not a danger to anyone else. But we go beyond that, or we should be going beyond that, by having a discussion with family members that know them, that have been through this experience that they're having with mental illness for years, and talk to us about, they're saying this, they're acting like this, that appears maybe benign, but I know that next in line comes X, Y, Z. We can talk to community members who interacted with the person and perhaps been out in public. And we'll take input from mental health professionals that are willing to talk to us, that are potentially treating those people or have prior experience with them. We can talk with our clinicians who have dealt with the consumers before and recognize that there's probably try to intervene. And so we gather information from sources other than just the person, other than just our personal observations, because we're only looking at a moment in time, but people that know the person are going to have more for us to help.
And so that also, that the baton is often then passed on to Michaela at the hospital. And so they need to have necessary information too, because we're not going to probably spend, I don't know how much you're going to spend personally telling them what's going on. I know we have this form, which you sent me a copy of, which I distributed to everyone, with the HCS 1801 form, which was recently revised. Tell us how this form is used in the field by the officers.
So when we're done with our investigation, it's a come to a conclusion. Tell them, hey, you're being detained, we're taking you to the hospital. Then we get to the hospital with this form, and we will fill it out with the information we've gathered and include on the back right here at the top, people we've gathered that information from, so that when Michaela and her team comes into this, they have our verbal report to medical staff, and they also have kind of the path we took to arrive.
One of the questions okay, no, we're not taking questions.
I was going to answer.
No, we're okay. Just write it down. Write it down. Okay. Can you hold that and hold that right there? I just wanted to just thank you. So the gravely disabled is, I know for me and Chris in the criminal justice system, we're often like wondering about that gravely disabled because the first two criteria aren't met. And sometimes I feel like it's forgotten piece. And that's just my perception. It might not be true in the field or at the hospital. But how common is it that we take someone to the hospital because of that third criterion gravely disabled? So
in my experience, speaking just from me, gravely disabled is something that I have not used as much because there's often a need to gather more information under that. Like it's, in my mind, like pretty simple. If I show up dealing with somebody in crisis and they're eating a handful of rocks or something that's inedible, it's clearly to cause them some sort of basically harm. Yeah, of harm by engaging in that action. That's clear. But the gravely disabled situations that I'm thinking about are ones that we've had multiple contacts across a time frame with people, and we've observed behaviors that are incongruent with being well and healthy. And maybe we've even seen decline. There was one gentleman years ago that over the course of 6 or 8 months lost so much body weight. And he was very good at engaging with us and telling us what we need to hear, but by talking with families, seeing the physical decline became clear, he was really good, because he wasn't engaging with food items correctly. there was a lady recently that spoke in North Davis that when I first went out to talk with her, I don't know, 3, 4 months ago, it's clear there was a problem, but I didn't feel there was enough to take her through the stable until we had additional contacts and show that like this isn't just a one-off, one point in time. This person is not doing the things they need to do well, and in fact being harmful. So in my experience, real stable takes a little bit more work, a little bit more interaction than simply I want to kill myself or
So I want to ask you something now that also Chris and I see a lot, and it's one of the most frustrating or distressing things that I see, and I know it's sometimes unavoidable, but I get a report and it's just a welfare call, okay? And cops go out to the scene, whatever agency it is, and then it's triggering, and it turns into a crime. Like, let's just say it's a fight between the individual and the cops. And so now you have an arrest. So the question then is, what path do you take, right? Because even if there is a crime, correct me if I'm wrong, you could go to take them to the hospital. Okay? How is the decision made? Because jail is a bad place for people like that are in this situation, that are having a crisis. I mean, I understand certainly from my perspective and my work that sometimes for public safety reasons, it's the necessary place to go. But how is that decision made in terms of which path to take? Taking the Raquel at Center Davis or taking them to the jail?
Yeah, that is a complex decision process. It's multifactorial. You have to consider what's the severity of the crime here. And if you ever get a chance to look at the City of Davis policy on responding to illness, it kind of outlines the decision-making process that we need to engage in. It's available online at the Davis PD website. But if the person is engaging in something that's low-level crime, and it's likely, if it's nonviolent, it's very clear that they're doing this because of the mental illness. And we believe that the behavior that they're exhibiting is not likely to victimize hospital staff. And if it's a low-level crime, it's truly in the best interest of that person and the community to try to engage that person in certain behavior. Where it becomes, I think, less clear on what to do is if you do have a situation where the person has been violent with other people, or during the attempted detention or the interaction, the person you end up with a felony where someone is hurt, whether it be the officer or a bystander. At that point, if it looks like the person who's in crisis is not going to be safe to be taken to the hospital, and they continue to victimize the current hospital staff, then all day long, after consultation with Rob, or one of his people, I'm gonna tend for doing a bias for and the idea is not that I think that jail is the perfect place to solve the problem for someone, but if the hospital doesn't have the resources to handle a very violent person who's going to continue to victimize others, jail is more stuff to do that. And my hope is that if we can get the person involved in the process in a certain way to get them engaged with help that will stop this behavior in the future. Kind of playing the long game, makes sense.
So the next question is restraints, or I guess you could say that's, or I guess there could be other types of restraints you use successfully. When you take them to the hospital, is protocol that they're in some sort of restraints? And it reminds me of the situation when family member's friend was actually taking 5150 in LA to UCLA and sat in the hallway of the hospital waiting to be seen and was handcuffed to the chair for hours waiting to be seen in the hospital. That's Los Angeles, I realize. But can you talk a little bit about that?
Yeah, my hope when I take someone to the hospital is that we can do it without. They're not fun. No one appreciates it if you're already in crisis. In my mind, that's not going to help anybody do anything. The place that many law enforcement officers make decisions, is this person potentially violent towards me or the hospital? And if there's a perception on the part of people that were involved in the investigation, consumer to be violent, but has not been violent yet, I am very likely to put someone in handcuffs and take them to the hospital in handcuffs so that we can prevent harm to officers, prevent harm to medical staff, and keep the person who's in crisis from maybe catching a police crime, committing a crime themselves, which we don't need that. If the person has been violent with us fighting, then we may use a restraint that is greater than handcuffs. We have a device called a safe wrap device. It's designed to immobilize the person's legs, keep them sat up in a position where they can breathe, with their hands behind their back, and then they're monitored by the hospital. If you need to, we will have ambulance come out and do the transport from officer to help keep the staff and the ambulance safe. But those are sort of the, I guess, the three levels of the restraining order. And then use it how we might.
Getting back to the co-responder model, I know that you don't have, unfortunately, in the perfect world, we have the co-responders with you 24/7, but we don't have that. How are things different when you don't have a co-responder social worker on your shift?
Right. Then we'll call the mobile crisis team. They're available, I believe, from 8 to 8. Right. So right now our clinicians are Monday through Friday during daytime. We have to have the correspondent model. We reach out to mobile crisis. As I understand, it's specifically trained paramedics. So personnel will come in, work on it.
Right. So when you take the person to the hospital, how long, at what point do you leave the hospital, the officer?
So our idea hopefully is that within 20 minutes, we can complete the transfer from law enforcement to hospital staff. If there's a situation where someone is unsafe or the staff is going to be unsafe, we may stay a little bit longer, but the idea is to complete that transfer as quickly as possible so the person can begin their medical evaluation and once that's completed.
Now on the form, I know there's something that you can check, which is relatively new, where you can ask the hospital to contact you, law enforcement, if the person doesn't meet criteria in the hospital's system. Is that, how frequent is that used, or is that box checked, and why would it be checked?
In my experience with Davis PD, we rarely check it. We have done it a couple times when the person from the hospital in some larger issue, and there's a larger safety issue, accountability issue for the community, that this person is police, there may be harm done in the community, or maybe it does something that they do to be held accountable for if they're not receiving help from the hospital. Qualified for that. If that help the hospital, then we will ask that we do that. But again, like I said, my experience done very rarely.
We've heard about situations where, let's say there's a call from mom about her adult son in an apartment, separate apartment. And the son, let's just say, is important for mom, calls in and says he's going to harm himself. And you go to that house or the apartment and you knock on the door that individual doesn't answer the door. What is your ability to go in without that person, letting you into the home?
So we can talk about ability, and then we can, I think, talk about a couple of wider issues. I can go into a home and essentially violate somebody's Fourth Amendment rights to be free from unreasonable government. If I believe that there is some sort of exigent issue, some sort of emergency requires someone to intervene. What that might look like is, in another case, if I show up at a house where we heard there might be a fight, we can hear someone being actively injured or hurt in the house. We may force entry to save that person from further harm. In the case of a call like this, where I don't have a crime, the exigency might be that I look through the window, I see a person down on the floor, they appear unresponsive, injured, or in need of medical assistance, then I might do something to force my way. In absence of that, the person who's in the home not doing anything criminal, even though they might be having some sort of mental health condition, they're still protected by the Fourth Amendment. And I think we have all seen situations where law enforcement, under the guise of trying to help, forces entry into a home. A confrontation is created with a person they're trying to help is injured, killed. And I think we can all agree that while that's happened in the past, that's not great. We certainly don't want to continue doing it. So if I had a call like the one you're talking about here, I would try to get their information first from mom, from people who live nearby, people the person interacts with. And then when I go to the house, I maybe knock on doors around the house, hey, just need stuff. And ultimately, if I'm knocking on the door and I'm not getting an answer, the person can choose whether they're in crisis or not, if they want to interact. And if they don't want to interact with me at the front door of the house, maybe I'll give them a call and say, hey, this is Josh. We got a call that you might be in a crisis or want to hurt yourself. We'd like to talk to you about that if you're willing. Have a discussion first about where they're at, whether they work with us, maybe engage with a co-responder. If it becomes clear that the person is in crisis and that there's going to be a potential violent, bad confrontation with that person, as frustrating as it might be for the family members, these days, probably in the past 5 years, and so we're no longer going to force entry to hurt somebody to save them. That's just not the antithetical to trying to help someone. So does that answer your question? Is that
and I mean, there may be some other questions. The last question I had, and so our board was interested in how things are different with children. And I know when I was thinking about this, I was thinking probably in most cases with children, it would be family members that would take them to the hospital. But are there some situations where you go out on 150 and it's a minor?
yes, absolutely. And because there are minors in many situations, a parent. And if the parent has enough control and influence over the minor's behaviors to be able to take them to the hospital, then that's what we will do. We will offer this voluntary engagement with services over forcing the child into services. There are some situations where it's clear that if we don't have that voluntary hold, the family members won't be able to help the child, and the child will not get the help. So in that case, we will use the voluntary hold that be personally unbiased towards.
All right, I'm going to move on to Rakayla, and then when we're finished with Rakayla and Rob and our board will have some questions, I'm sure. So Rakayla, you're obviously you manage a very specialized group in the hospital. What type of training is your team receiving to manage these very challenging clients, patients?
So all of the staff on our PRT effective team, all of our PRT staff are either licensed clinical social workers or associates. All of us have that training. Most of us also come to get the hospital background. And some of our staff have worked in psychiatric facilities, which is where the things go. Excuse me. Oh, yes, sorry. Way over here. Touch the wall. Yeah, so all of our staff are either licensed clinical social workers or associate clinical social workers working towards licensure. We all have a social work background, we're all state registered with the board, and almost all of us come from a psychiatric background. So we all have experience in the field, and we do on and training. So most of us right in facilities where you take anything, the evaluation, and work on stabilizing from that point. We go through, we do 15-50 verification through the county online, with even hands-on things in the hospital. So for the supervisor, I facilitate all training for new staff. So like I said, most of us, we all come from a mental health background. So our training goes in
And what are the types of ways that patients are coming into the hospital? I mean, one way out is obviously with Josh. What, other than with law enforcement, what are the other ways that someone might come in where you might be evaluating them?
So they might use the law enforcement, sometimes they call themselves and they're brought in by ambulance, they're volunteering, they're on pay, and they come to the hospital, suicidal or had hallucination, and they'll pull the person in. Sometimes they walk in, they check in door, front door, and check themselves in, or a family member kind of bring them in. And that's typically most ways you can come in voluntarily or involuntarily already out there.
And how are these individuals treated differently?
There's no difference in how they're treated, whether they're voluntarily or on a hold, things like for. So if they're already on a hold, if we're going to evaluate to either uphold the hold and continue on it or discontinue it, and voluntarily sure that necessity is the criteria for be placed on a hold, or if you voluntarily go to the hospital, or if you're okay with this.
So when someone comes in and says, what Corporal Elton was talking about, they're, aggressive and somewhat violent, I know that's not common, right? How do you address that and talk about restraints and whether they're put into seclusion? How do you deal with that?
And so we do see it sometimes people come in and how severe their authority comes back to or that. At that point, for their safety of all the other students and hospital staff, sedation. So it is medical sedation. We don't try to put people on the break. We try our best, so my team, whether myself or one of my colleagues, we are down there, and, like what we would do when we can drop somebody off to get report, and we stay from the beginning. So we'll try from the employee to evidence that if it's not helping, they're removing towards medication. So it's not helping for anyone that is taking in that state for that other time. We actually would have it or responding to internal stimuli or responding to anything that's not helping for them. And so medical sedation, which helps them calm and relax, and then follow up with them once they learn off. Typically, once they sleeping the rest of the time. But we only use restraint when we're actively aggressive, combative, or staff. So there's like if somebody's actually throwing stuff at us or trying to kick and fight us, at that point, that's the only time. And then we follow take those all for restraint. So we're catching it in, if it's okay, we're going to do try that's not restraint. And they don't really need it. So if they're off in the restraint, that would mean that would mean.
So Corporal Helen talked about the criteria for different issues. Can you talk a little bit about that too from a hospital standpoint?
Yeah. So 3 criteria for each criteria for people. Your dating to self, your dating to others, or your dating to disabled. From my experience, what we see in the overall county primarily is the dating to self or dating to disabled. You don't get too many things to others. Usually if they're dating to others, they're also meeting criteria for dating to disabled. But so dating to self, you're engaging in users that keep on for that your life, or you're actually endorsing self or playing stuff on yourself. So for instance, the most clear one is, hey, I'm having suicidal thoughts, I have a plan in my life. But also somebody is there with like severe psychosis that they're walking in the middle of the street, or they're trying to jump off the building because they believe they can fly and that they're a bird. You can be criteria for things that also because there's so many things scared that you're making unsafe choices and your behavior is going to disregard for your safety in your life. Which also pertains to others. You can say, hey, no, I don't want to hurt anybody, but it's like in the legal state that you're thinking that person down the street tries to kidnap you, or your neighbor is part of the CIA and how to get you. Sure, that there's a body on to that. Because you're people, we criteria for more than one area. So it's not uncommon. For all areas of something to other things that you say, depending on their behavior and your presentation. For grading behavior, so grading disabled, other things that come to the wall, but you're unable to provide for your students both income, right? And some people are, they're like, hey, I have a home, I'm fine,
Other than your observations of the patient and your interview of the patient, what information are you gathering in the hospital to determine whether the person is criteria?
So typically, if somebody's brought in by a crisis clinician or by law enforcement, we get the report from them, that was the first point of contact. So we get their report. If we have any history with the patient, right, if they're familiar with them, we kind of go with it. We go through everyone's first. So we're able to see all their past records that they've been seeing for us before, by for 50 goals for a site down. Also, we have a tool where we're able to see outside records that they're available to us to see how many times they've been to another hospital for similar presentation, or if they had a history of mental health disorder. So we get the information from here, and we do our assessment, right, with the first thing, that is down. But also, we try to make collateral as much as possible. So what happens our technical therapy services, we'll call that service agency. They bring us to the cooperative. We're going to call and contact with their case manager and get some support about what's been going on inside of the clinic. If they have a family member, we're going to take them to talk to this person, get more information from the. So we'll talk to the well, okay, if they're coming to school, to the primary school, hey, talk to the school counselor or counselor. So kind of make as much level as possible is it available. For some instances, they're typically with population so at that point, we're going based on our evaluation and how they were brought into work.
So let's say you have an adult who's you're saying that you decide these criteria and you have a plan and you know where they're going to go. And mom talks to you. There's no release of information. And mom says, what's happening with my son? What do you do?
We don't know. You still have a right to privacy and confidentiality, and we can't violate that because they don't know what's going on. So in that instance, I would go talk to my state and say, hey, look, your mom's at home and they want to take it, so if I can this information, they can know. Then I can. Now, there are certain circumstances where we can, depending on what's going on, right? Depending on how severe someone's symptoms are. If they're not in the right state to where they're like, oh, yeah, my mom's door flip, that's clearly that they're not in the right state. And for continuity of care and make sure this person is receiving the best support and that they have some quality after, we will do it at that time. And we'll be forever documented based on why we're making that decision. It doesn't happen that whole thing, but if there are certain circumstances for that, it's really unsafe, we really know what's going on, and it's really important for this person's care. And then when they go to the community hospital, for them to have some support and understand what's going on, then we will. But typically, if they say no, then we can't provide that information.
So I know there was a time when you would wait for an on-call social worker to do that assessment, and that could take hours. And I understand that's changed as of some time back.
So that's what my team is there for. We are stationed in our Monday to Friday, we are there 20 hours. Over the weekend, we provide 24 hours here. And so we are strictly there for psychiatric evaluation. So if anybody comes in on 51 people or in need of psychiatric evaluation, we perform those.
Talk about the role that alcohol and drugs play in someone.
So they think we see that we're being more of the lower counted. Methamphetamine. Most people that we see who come in if they're on a regular basis are under methamphetamine. Methamphetamine, substance use psychosis is very severe. Essentially, depending on, we don't know what the substance is mixed with, but it's very severe and it can mimic symptoms identical to schizophrenia or bipolar affective disorder or schizoaffective. And so typically at that point, we don't necessarily come with substance use, right? You're still experiencing psychosis, you're in a state where you're not linear, you're not able to really care for yourself or your friends at that point. So you can be placed on a hold if you're under the influence of substance use, called substance use psychosis. But at that point, we still need to run medical evaluation. So every patient comes to our ER, whether they're on a hold or voluntary, they are seen by a doctor, they have a medical evaluation, rule out the medical treatment for that. Their symptoms or medications are not being called by medical treatment. So once they're medically stable, then we will our assessment. Alcohol is different from other substances. So we wait we have a lab draw, the alcohol level is over 100 for the hospital lab. We don't see them at that point because based on what we found, we're still clinically complicated at that point. So it's not appropriate to do an evaluation while you're clinically complicated with alcohol because it's different from second or the life frame of it, how it's different. Also, alcohol is different, whereas statement, it doesn't typically cycle. And so we'll wait for the next clear. For example, I have hospital or alcohol in 37. Okay, we're gonna let it go there and we'll see what's there. And so once there's unique areas that is clear first, so and then we do them. So sometimes somebody might come in on a hold and do something while they're complicated, and then we clear up and then we're gonna do that. And we go based on their mental status exam and our observation, that thing. Monday through Friday, that we have the participation here. And so if it's anything substance related, we do give them called a sun consult, so they can get substance services, whether that's inpatient or outpatient. Same for also the other substances. So anybody with substances, we try to connect them with this time. It's up to them whether they're follow through or to complete that assessment, or we will follow through.
What do you do if someone does not meet criteria?
So if someone does not meet criteria, depending on their insurance, we'll try to refer them to their services. So if they're a college student, we Davis, we try to connect to the counseling center and get them set up there. For their health, if they have partnerships, we call access and we'll see if we can set up on the phone. Private insurance, we try to get things right in mind. We try to get on the referral there. We don't have to do about a big team that we refer on their expressing. So we try to also look at something possible and connect it while they're still in the money zero before they're starting them. Now, so they don't discuss them, but we will also do it as possible and then they're just starting.
What if someone does meet criteria?
So if you meet criteria for a hold, whether we're placing on a hold or you came in on a hold and we're going to substitute it, the next point will be to transfer to an intake psychiatric facility. So, and then take it out to that facility to where you'll receive or whether for Yellow County, you refer to the processing places and they will still be for partnership. And the other ones, we refer to our access center for Sutter, and then they will send out a referral to now we have a referral portal where it goes to every psychiatric hospital within 75 miles. And they'll be expand that knowledge up to 300 miles to get you with every.
And if mom says, my son, adult son had a really horrible experience, I was going to name the hospital, but I was just throwing out there, but I probably shouldn't do that. What do you do?
So we have that happen more than not. And then from a lot of us who have education backgrounds, typically when they make certain places we're providing the understand. We cannot say, hey, we're gonna exclude. We try our best where we'll say, hey, can we not be referred to that hospital? Because they had a really traumatic experience there. Sometimes it doesn't perfect. I don't want to conclude there. But if it's something where you had a really traumatic experience, we're taking that into consideration. The goal is to get you care. Right, and if you're going to be in a place that's more stressful for you, that's not going to be beneficial to your care and your treatment. So sometimes we'll say, hey, you know what, can we hold off on referring to the hospital? We don't want to referral them because of this. And so we will make that private accommodation possible.
Who do you ask? You said you asked that. Who do you ask that?
So we have a patient access center who manage those referrals. So once they receive the referral packet, typically we try to get on place at one of our other facilities. And if we can't get up there, then it opens up the portal everywhere. But we will say, like, I had a minor who said, I really trying to experience the hospital. Some people are not going to get better, and Aaron was for permanent and said, hey, please not send my child there. And we need to say, hey, please do not send the referral to that hospital. But open it up all up. So we will try as possible. One of the three.
So speaking of minors, and I had asked Corporal Helton this. How are things different if it's a child or teen versus adult?
The evaluation process.
I'm sorry to interrupt. The public's really having a difficult time hearing. Yeah.
Sorry. So the evaluation process is the same, just a minor checks in, everybody gets medically evaluated by a doctor first. And then once they're medically stable, they're assessed by the. The only difference is sometimes we run into parents not wanting their kids to have treatment. But based on our evaluation, the minors are more forthcoming with their symptoms and what they're experiencing, rather than what they told their parents and what the parents know about it. And the parents like, well, I want to take my kid home, and the kid wants to take the treatment. And so at that point, that's a conversation like, and I'll look for that. We're going to put in the process. And we've had this more often not where the minors actually advocate for themselves and get help, and their parents are against it. But it's the following thing, criteria are based on a whole. There's not really community assistance. We have minors who are voluntary, where they're wanting treatment and the parents wanting treatment, typically over maybe 16 to 17, so higher age adolescents, where they have a bit of insight to understand and review communicating what's going on, and the parents are supporting them.
All right, Rob.
Oh.
Okay, so, and Rob's been nodding, which is great. He's been like-
Because they have all the right answers.
I know, and I saw Josh too, has been nodding also, that's great. So you've heard all of the discussion here, talk about the role that, Yo and Health and Human Services Agency.
Specifically to my team, the crisis services, we break it down in essentially 3 different sections. We have the mobile crisis, which, and that's Monday through Friday. Am I speaking loud enough? Okay, great. I usually have a loud voice. Anyway, so and those are the ones that generally help the emergency rooms find placement for those clients that are out there. And then on top of that, we do have our hospital discharge plan. And so those individuals are tasked with developing discharge plans as soon as somebody comes into a hospital to make sure that they're not going to fall through the cracks. And part of that process is also to make sure that when they're discharged, the solid plan is to make sure they have the capacity, the ability to make those appointments. So that is really our place right there in working with the community, working with providers out there. On top of that, the overall agency provides a lot of services for that medical health population and those people that are in crisis. And so we have a lot of different programs, FSP, the Full Service Partnership, Children's Services. So we try to go ahead and make sure that those individuals that are needing services, we wrap around as many services as we can. And we have staff meetings with our own staff and then also with other agency providers to make sure that those individuals are getting the case we need. We have weekly child adolescent emergency room meetings in which we're making sure to identify those individuals that may be having trouble and that we're making sure that we're providing either enough services to keep them out of the emergency room or when they're no longer in the hospital or out of the emergency room, that we're following up and making sure that those individuals get the services they need.
Thank you. Can you talk a little bit about CIT training?
Just a little bit. So CIT is a evidence-based model that started in Memphis. Unfortunately, it started in Memphis as a result of a tragedy. But then it brought the community together to come up with a plan and a program that's just been really adopted nationwide. Actually, it's national or not national, international. They have conferences every year that we see people from Canada, Europe, Australia going to attend these programs. So, you know, it's really a very solid program. It's really to teach law enforcement. I get a little excited about this. CIT is really 2 things. One is working with law enforcement, teaching them about mental health, teaching them de-escalation, teaching them about psychiatric disorders, and also teaching them about what behavioral health services the community have to offer, and really working in to get that officer or whomever's attending the training to really be able to go ahead and access those services, know how to access those services, and what those services can provide. The other part of CIT is to develop a community intervention team, and those are stakeholders in the community that law enforcement, we work with NAMI, we work with Alta Regional, we work with a lot of different agencies in order to identify individuals that we might have contact with that might be high utilizers of services, that we go ahead and get those services connected. And part of that is the CIT concept is to get the community involved and also to educate them in what the other providers can do, so that we don't have any false expectations of anyone else. We know what law enforcement can and can't do. We know what a hospital staff can and can't do because we're constantly communicating back and forth. I think that's kind of CIT in brief.
Does your team do 5150 evaluations?
Working with law enforcement, yes, we do 5150 evaluations out in the field. Like Josh was saying, that sometimes law enforcement is really busy, and we have the capacity to go out there on our own. Safety is the paramount of anything. Safety for the individual, safety for the community, and safety for those responding. And so once we have an idea of how the scene is, then we'll go ahead and look at responding. We will do the evaluation. Even as law enforcement there, we're going to go ahead and do the evaluation. Partly because if we're there, law enforcement's role in that is again, really to provide that safety and support where we can really focus on the mental health aspect. And that's part of what we do out in the field when we're with law enforcement. We also do the 5150 evaluations in the clinics as needed. And, you know, we are responsive to the community's needs. So if there's something out there, someone out there that's in need, it's not so, and it's not just going right to the 5150 evaluation. Part of it's engaging the individual, find out what's going on, what brought them there in the first place, what can happen to not get them to that point, what resources can we get started. If they're an FSP client, a full service partnership client, let them get them to the right spot. Let's get them to their case manager. Let's get their doctor involved. If they're short on medications, let's look at getting the medications renewed. Or, which I really like, is that some of the providers, law enforcement, they've actually brought individuals that are in crisis to the wellness center. Granted, they talk to them, make sure it's a safe environment, that they're gonna, you know, be okay. But they'll take them to the wellness center, and so the wellness center has been utilized quite well as a deterrent or as an alternative to 5150.
What about individuals in custody in our jail that need to be evaluated? How does that work?
So Chris should probably answer this question. Individuals in the jail, and according to Welfare Institution Code, if they are currently in a facility that's caring for their basic needs, the 5150 doesn't apply now. If they're going to be, now they can have an evaluation, a psychiatric evaluation, which is different than a 5150 evaluation, and that can happen in jail. But the 5150 evaluation actually happens upon release. So if they're being released, the judge has given them minute orders or whatever the case may be, their time served, then we'll go ahead and be the ones that provide that 5150 evaluation.
What's the role of HHSA when someone doesn't meet the criteria? How are you guys involved?
Given whatever situation, we have individuals that walk into the clinic for triage, and we connect them to services with the appropriate level of care. When we're out there in the field, you know, and it's just not those 5150 calls that we respond to. You know, there's sometimes we have parents and their children that are having a difficult time communicating. We have children that are being bullied. We have disturbance calls. So we respond to a wide range of calls and disturbance calls or whatever the case may be. And we try to really meet them where they're at, find out what's going on, and then get them to the services. And if that means that we provide them a ride or get one of our peer support workers now that we can get them to go sign on for benefits. Or we've actually had individuals get back because they don't know how they got to Yolo County, and we get them back to their county of origin. We've driven individuals over to urgent care in Sacramento, where they're receive services, so we'll do whatever it takes.
And the same question to you about how things are different if a person is a minor or a child.
As far as assessing them, 5150?
Yes.
Okay, so it gets a little tricky. So there's a latency age, and so there's a certain age where you are observing the behaviors of the minor, and you're looking at, are these behaviors consistent? But the majority of that information on the latency age is if you're getting that from the family, you get that from their physician or pediatrician. You're looking at a lot of the different collateral information from teachers or education. That's a latency. Adolescence is a different thing. We still, like Josh was saying, we get collateral information. Part of the welfare institution code says you shall take into consideration history and collateral information. And so that's something we did. We work with the kid. We work to give people treatment in the least restrictive manner that is safe. And so that's our goal. And if we can get them a follow-up appointment, the next day appointment, our children's mental health providers do a really good job of engaging the clients. After we're done seeing them, the next day they'll follow up right with them and get them engaged in service. Oh, I can't remember now.
So we shall consider information from people that know, like family members.
As far as the welfare institution, but yeah, it may clarify information that you shall take into consideration history and collateral information, family members, therapists, those individuals.
All right, I'm going to take some questions from the board. I know Nikki had a question.
Actually, I have two. Sorry, I'm recovering from bronchitis now. Voice is still reliable. On the Sutter Davis thing, when you get someone in, with the new remodel of the emergency, do you have any dedicated mental health beds?
We have 4, and we actually have a really nice facility located at the end of our new ER, because if people are here for medical treatment, and on top of your anybody who, whether they're on a hold or voluntary, anybody who's been designated for a psychiatric evaluation has assigned staff looking after them, watching over them, and taking to the treating nurse. So they have this to make sure that they're safe, to observe their behaviors, and just make sure everything's okay. So we have 4 designated rooms. There are the end of our emergency room, towards the back, and we have a nice space where we have garage doors. So they can say, I go to medical equipment on the wall, so that way they don't have to protect on themselves with. So it's kind of a bare room at that point. So when they're not, when we're not creating like in that room, it's back to a regular room. So we do have with the expansion, we have that data set now.
Well, that's good to hear.
I do want to say, in the 30 years I've been doing this, Sutter probably has the most well-planned, well-thought-out emergency room for psychiatric clients, in the way that it's away from all the noise. It's very, the lighting and everything, the things like that.
We used to have the hallway.
Yes, you had the hallway.
We used to have the hallway.
I have been there when the hallway's been occupied.
The hallway is the thing of the past. We do get those designated like, yes.
Thank you. All right, so I also have a question for you, Josh. When you all are called to a home or someplace where someone is suspected of having a mental health emergency, about how often is it that you have to use unusual force or draw a weapon, something like that?
I don't know that I have enough information to give an estimate.
Okay.
And this is also online in the Davis Police Department manual. We have our use of force policy.
Mhm.
Our use of force policy is governed by California state law and decisions from the Supreme Court. But generally, clients go on public policy. I'm not going to exhibit my weapon unless I believe that there's a defend myself or something from a similar, not same, but similar danger, right? So if somebody has an edged weapon, could ruin anybody's day really quick. That's a legal problem. So in that case, if somebody actually has a weapon, they're talking about thoughts about using it, they're telling me I'm going to do X, Y, Z, then I'll probably try to disengage, find cover. And at that point, I may draw a weapon in preparation to defend myself. But the idea that if we're able to separate them from that weapon, it could be potentially
Okay.
and if it's not a legal threat like that, if it's someone who is visibly fighting for whatever reason, legally we use the force that is able to overcome that resistance. Reasonably, right? If somebody is just simply laying around and program pulling their arms in, I wouldn't start punching someone or dropping them. But again, in 18 and a half-ish years, while I've had to, it's very rare.
Other questions, Brad?
I have a question, since you see Rob,
Yeah,
it sounds like you have really solidified the team.
continue improvement.
Cool. Does my role still exist?
Yeah,
Okay. And I was just curious. Cause I thought when the CIT first started that the whole reason to go out there was to subdue and not make a 5150 at all possible. Are you now allowed? I thought you weren't allowed when you first started to do 5150. I thought one of the police officers could say, okay, we've got enough, this is 5150.
so this is the first iteration of CIP was CIP, which you were involved in, and we would go out and we would do the crisis intervention if it needed to be to the point where a 5150 was indicated. We could break the 5150s instead of law enforcement.
Right.
I'm not sure if I'm getting your question.
I was just curious, because it sounded like it changed a tiny bit from when I was in the sense that, that the reason why the social worker was going out was to subdue the situation, not to make the, I thought the police officer had the final decision. Also, when you say clinics, you're talking about like the one
Here, yeah.
over there, or
Navigation center, or even those that's active.
because like I got the impression when I was on the team, I got the impression that yeah, we definitely wanted to go out with the police officer, but we really didn't want to do a 5150. We wanted to find them, set them up, find them the next day, and get service.
Yeah, we don't want to do the 5150. We don't. That's what, I mean, we initially start out where the client's at and figure out what's going on. We can do something. Like I said earlier, we're going to try to treat somebody in the least restricted manner.
Okay.
And so.
I'm sorry, I'm misunderstanding.
No, that's what, no. That's good. No, that it's been the same since you were there.
Okay.
Is go out, provide interventions, get them the resources. You know, if somebody is trying to harm themselves or harm someone else, or they're at a point where they can't take care of themselves, and if we leave the scene, are they going to be safe? Is the people around going to be safe? And the answer is no. Then, hey, do you want to, you know, just over this weekend, we had somebody go involuntarily. That could have been criteria, but they chose to go involuntarily, and that's what we did. We had to go involuntarily.
Yeah. I have a few more questions. I'm sorry, I don't know your name.
I'm John.
No, I'm sorry.
Oh, sorry.
We're Kayla.
Are you the one in charge of the clinician part of CIT?
No, so I'm in charge of the clinicians that are needed, and we do all psychiatric stuff.
So, but you, which is kind of my last question, is that Ruby North is still the only mental hospital in the county.
And in terms of designated LPS facility, yes, so Willow Mill Memorial is LPS facility, so they are in the. And so that's where people want their, for COVID for 5150, that's where you get the appropriate treatment back. So where that first point of contact, so they're doing some psychiatric evaluation in the emergency room
Oh,
to determine if that person meets criteria for a hold to go for.
And remember, Brad, the 5150 is an application.
I know
It
it
doesn't,
does,
yeah, so it doesn't guarantee somebody's gonna go into a psychiatric hospital. It's a constant process of evaluation.
Oh, I thought it was a 72-hour hold.
It does not, they can be held up to 72 hours, but it's a constant process of evaluation.
Right.
Somewhere along the lines, especially if you're dealing with an older adult and they're having bizarre behavior, you find out that it's a UTI, that they're urinary tract infection.
Oh.
And so it's not a psychosis, it's more of a medical condition, and so it takes a whole different route. The 5150 doesn't apply.
Right, I understand that.
Yeah, so it's that concept.
Yeah, I just. Makes sense. I was just trying to clarify things. I have one little quick question. Ruby North is really small. Are you guys frustrated with the fact that Ruby North is so small, or, because you can send them also to mental hospitals in other counties?
Oh, we refer everywhere. We will send everywhere. What I can say is, we take pride in that people request to come stutter when they're in crisis and they want an evaluation or they're in a hospitalization. We have to come from Colorado County and they're like, that ambulance like they request to come stutter.
Other side.
Stutter David.
Oh, Saturday.
Yeah, if they have to go to emergency room, they're like, take the stutter David. Always other side, but we take pride in that because that provides care enough that they'll feel safe and comfortable and know that they'll get the care if they're needed.
Right. Yeah,
I was just asking one question. I didn't know that there was a Sutter site you can build.
Sacramento, we have Sutter Center for Psychiatry.
Oh, okay. I was thinking Davis.
Correct. Sue?
Yeah, I had two questions about that. The first one is for all of you. If the patient is a child, as in the treatment process, we didn't get, how many of the people they encounter have gotten training that's specifically helped?
So I think for my team, I think our educator background, we are trained.
All of you.
And it's like, so anyone on my team is evaluated for a minor process, right? But I'm also taking consideration. Sometimes I call it 4-year-old, like that's not appropriate at all. Right, depending on their age, development, understanding what's going on. But everybody on our team, for my.
And then with the police, we bring some specific training.
Specific training for dealing with children who are in health crisis. We don't. We have the 5150 evaluation tools, and whether they're an adult or child, our evaluation looks similar, but we don't have specific training.
Part of the CIT course, though, there is a course dealing with individuals with developmental disorders and spectrum disorders. So there is that component that we work with the officers and treating them or training them how to engage with that population. Likewise, we also have the focus on individual depression, TBI, PTSD, and individual schizophrenia. So while there's so much information, we try to go ahead and give them as much information. And, the officers are really throwing out a lot of different questions out there. So, they're really involved in asking real life questions. So yeah, so many questions are definitely in focus.
Okay, so you're talking to like how to.
Yeah.
Oh, I'm sorry. And then my second question is just for Michaela. When you do have a parent regarding consent and they want to hospitalize the child, so then it drops from the criteria for an involuntary to medical necessity. What criteria are you looking for?
So it's different, right? Say a parent can say, I want my kid to be hospitalized because their behavior is out of control. That doesn't necessarily mean like, yeah, agree. And that's based on what their understanding of what they can provide and what kind of care they give it. So then having that conversation with the parents, you know, saying what are available to them and giving them education over there. Sometimes we go with parent-child interaction into that picture, but just because their parents want the child hospitalized doesn't necessarily mean any criteria for that they need to go to a specific place.
So at Sutter, are you only hospitalizing the child if they do meet the 5150 criteria? Or is there kind of an in-between?
So it can be a voluntary side, but like I said, that's typically, right, taking consideration their age development, their insight, and their judgment of situation. Sometimes we have kids that are like 11. I went to an immediate hospital because my friend said that if you're sad, you can watch TV all day, right? Or that's not really appropriate with somebody. Right? We have 16-year-olds who was advocating, really wanted help with their symptoms. They weren't able to get outpatient services through their parents' months. They did themselves help where we didn't need to place you on hold at that point. The parent and the child, they have good insight, good judgment of what they're going through, and the thought process there is where it's appropriate. So it's appropriate, right? That's highly unless it's and especially like the parents are not because it's an involuntary role at that point. We have people say, I don't want my child going to a psych hospital and the child then is sick, so I don't take their child out of the hospital. It's like, no, they're here involuntarily. That's what happens to find out.
So it sounds like you're saying that if you don't meet the legal criteria, then there aren't really hard criteria for when you hospitalize an arm to it. You're figuring for this.
I think that the one thing you said is that 5150 criteria and medical necessity often go together, but are not mutually exclusive. Medical necessity really looks at, of course, they yourself, other aid, but also is there a medication management issue that needs to occur? Somebody starting on lithium needs to go ahead and have these, dosages constantly change. And the safest place sometimes to do that is in a hospital. And so while they may not even meet 5150 criteria, but they could benefit from medication evaluations and all that, they would have medical necessity to go into a psychiatric hospital and generally, to be on a voluntary basis. For Center, I think also has partial hospitalization for minors as well.
We have PhD and IOP and partial hospitalization. We also have 24/7 psychiatrists that can perform medication evaluations virtually. And more recently this year, we have an on-site nurse practitioner who do medication recommendation evaluation in our ER 2 days a week. So we have an on-site nurse practitioner that comes every Tuesday and Thursday who can do medication evaluation and make recommendations for treatment. And then we also have our psychiatrist virtually that's available 24/7 or sometimes like, hey, no instinct is not necessary. We're going to try to get connected to follow up with your outpatient provider or if you staff to outpatient, but if you're open to medication recommendations by our psychiatrist.
All right, any other questions from the board? Thank you.
I don't know if this is still an issue, but if you have someone who is on a 5150 and you deem that they need patient bed, is it still a requirement that they have to go to an ICU segment? So like Center for Psyche to say ICU for regular bed and now without backup? I'm curious if that's true.
So you're speaking to level of right high to very severe where they need a higher level of treatment and being able to participate in treatment manner or so for example, typically people who are low acuity, people who are depressed or having anxiety, they're able to really participate in treatment, follow the treatment I would go from here. Or people who are high acuity, they're going or they're responding to internal stimuli, they're not really oriented to themselves or others or time. They're going to need a more intensive treatment at that point. And so what they do is they go take consideration, how are they presenting right now? What makes them get from whether they're running some collateral, the doctors are there, and then our psychiatrists determine at that point what the level is more appropriate. All right. That's also for anybody else, depending on what they're going to go to. not everybody goes to Sutter Site from our hospital. They can go to their hospital in the Bay Area, they're Sacramento, more recently, what our new portal, somebody did the whole hospital in the area. So we're expanding the available hospitals to us, but they do take into consideration what are the symptoms that they're sitting with and how severe are the symptoms and also their disease that happen.
That's good. So then it's not about it. It's not like you have to start in this highest level. So you're waiting for those smaller number of beds to turn over before something. And so it sounds like that
Yeah.
that should improve the throughput.
Yeah, so you don't have to start on a higher level to get to a lower level. And with the more, like that, with our expanded availability of hospitals available to us, we have more options for those beds, whether you need a higher level bed.
Chris,
Pretty quick. How often is it you can't find a placement for someone who holds being technical? You're short term at Southern Davis. How often do you experience a challenge finding a placement?
Typically, we do really well. Most of our people get out in the literature. Now, the only time it typically runs past that, we haven't had these new certification hearings, so last year, 80, we started doing certification review hearings, and we started second 51, which means they've been in your reservation of your 72-hour hold, and we still determined that they meet criteria and meet what we still do. At that point, they have a hearing with the right, which is right advocate in the California hearing officer in the ER to determine if we're going to keep that hold or if they are okay with this part. Typically, the only time we actually do find the bed is somebody has severe symptoms and they're not willing to take medicine, right? And we have medicine to take them. That's going to be a barrier to them taking treatment in the time of that. When they're aggressive or they're combative. And so we really try to make it that before it doesn't happen, because also you're not getting appropriate care in order to go further with the problem at that point. I think it's still more equipped to manage the needs at that time. So at the moment, I don't think that we've been doing really well. We get our people out, get them placed, so they get that time to time. But at the moment, probably like by day 3. And typically, if it's stuff they can do, at that time, by 3 days, they might have metabolized and they're clear at that point. So where you feel more comfortable and you're no longer a threat to your other than risking the family to care for yourself. So typically, if they're metabolized, they're able to discharge. If not, we'll go into that maybe 4 or 5 day stretch, but it doesn't happen too often, fortunately. We're very, very much about that.
let me see, before I get to you, Brad, anyone else? Yeah. Questions? Yes. Maria, I'll go Maria, and then Joe, and then Brad.
So Josh, I just had a question. You mentioned about folks on homes for person who lives in hospital. What is sort of that transition plan between you to those jail? Because their counselor,
And to clarify, simply being in prison is necessary.
Right.
It's if the person has had the opportunity to take the aggression. Going. From my side of things, we'll let the jail know, hey, here's what we were doing. Here's a symptom to see, and then it's up to the jail staff to connect with the resources and maybe one of you speak more. Go ahead. Okay.
Yeah, so generally, depending on the charge or whatever, actually, you should speak to this whole thing right here. Both of you, is that once, there is, Pat, thank you, that works through the jail to go ahead and provide not only the medical and psychiatric services, and they identify those individuals that may need. And so I think also with some of the training that law enforcement's had, also able to identify those individuals that may need for evaluation. And we do have a forensics program. We do have go for it. Thank you.
The WellPath provides psychiatric services in jail. And so they'll try to engage the person. A psychiatrist will come in and can do prescriptions if they have a person has a history, want to get the medications that they have. They do have the ability, working with county council, to do involuntary medication if it gets severe enough, where that's necessary. And the police reports come in, we get custody, we get evaluated, we try and identify individuals with mental health issues. We have rejected some cases, and have been released 5150 out of the jail. One of the situations, if a person is suicidal, law enforcement responds, it turns into a brawl because the person is not, the turns that person ends up in jail. We see it, we can then decline the file. We want to coordinate to make sure that when they're released from jail, they're going to get a 5150 evaluation. So I call Rob, and he loves my calls. And so we've done that, or we identify it and notify the founder's office that we have a person leave us serious mental health issues, and then they'll sign something that mental health team hopefully can go in and we reach and try and track it out.
Jeff?
I just have 10 questions.
Okay.
First, my first one, my experience in the past, I'm glad to hear this gotten better. Choke point was placement for a while, especially in this kind of difficult to find placement for a while. Sounds like expand that the range of opportunities and range of places. So I'm glad to hear that. And I just want to hear about a couple of challenges. But before I ask, I want to ask you what percentage, based on just anecdotally, your time, what percentage do you think used to go to jail first? And it sounds like you could completely turn that around and how it's drastically different. I think folks need to understand that's no longer, the first choice. And anecdotally, what percentage do you think now go to the hospital first as opposed to jail?
Yeah, I don't know that I can draw upon all of it and give an answer that is of any value. But I do remember when I first started, we didn't have CIT training and co-responder model that sometimes, because of the way the interactions went, that the jail was what happened. I've never, not in my career, thought that the jail would always be the best option. If it ended up there, it ended up there. But I can't say that in sort of the time that I've been there, that the officers I worked with has thought that when somebody's in mental health crisis, the jail is the best places.
I just think probably the resources are now.
I think there are a lot of
folks, and I think that probably changed it.
And even like 608th Street, that's great because if they don't want to go with me, they want to maintain autonomy, they don't want to go with them anywhere. But we can provide a map showing people you can go right here, here's what you can expect. Having those resources that we have open up a lot more than.
And I just have a question with the field program. You have access to more information based on your permission than traditional law enforcement would have when you're making a decision.
The information the law enforcement has is very valuable in making some of these decisions. We have access, much like you do, to a lot of the medical records, and part of that is coordination of care. And so we're able to go ahead and get a lot of information from primary care physicians, treating psychiatrists, therapists. Law enforcement also has that capacity too, but it's learning how to navigate it. I think is because we've been so siloed, and part of that CIT is learning how to navigate that stuff. That yes, we have more access because we're more familiar with it, and we know the jargon. And so, when I call up a primary care physician, hi, this is Rob Villarreal, Crisis Services. They're like, oh, okay, let me get out of my client's appointment right now. Let me go ahead and work with you. Law enforcement could potentially have that too, but they're not familiar with the terminology.
No.
And then also like with Tony's staff, when it comes to children, Marianne does a great job with her staff in making sure that there's follow-up, but also if we're on scene or if they're aware of something that's going on, they'll let our team know. So at least we're prepared to go ahead and have some information ahead of time in which way that we could go ahead and steer the interventions.
Yeah, and the answer to, I just wanted people to understand that the decision is just more informed with this type of program and your professionalism in the field. So, I guess the other question I have is the sort of the joint response team is kind of a new concept, I think, in California. I know it's caught on a lot less in the last few years. Is there an organization yet that allows you to network with other cities that are doing this? Kind of talk about best practices, and so in law enforcement, I know that that's the way it works, right? You talk, whether it's an intelligence organization or CNOA or whatever, they get together and they work through best practices and be regularly, is that set up yet?
Well, you know, one of the most amazing things you'll ever see is going to the Crisis International Conference with about 5,000 attendees, half of them law enforcement and half of them social workers. It's the weirdest thing, you know, and they're all just very passionate about what they're doing. There's one coming up in August that, you know, different programs provide presentations about their programs and offer to do networking. And so that's something, as a matter of fact, there is a California CIT association that does a lot of cross training. You'll find Orange County Sheriff's Department, Ventura County. They'll say, "Come and visit us. We'll show you the whole program." You know, so yeah, those are very supportive of each other.
Thank you.
Brad?
I'm very sorry, it's Raquel, right? Raquel, I'm sorry. I'm sorry if these questions are right, but, so does the big 150 now start actually at Center? Do you work in Center Davis or do you work?
Yes.
Does the big 150 now start in Center Davis?
No, it can't start based on money. If law enforcement brings them in, they might have, if they see the 5150 and place them on an involuntary hold, or maybe the price commission, place them on a hold at that. So if they already come in on a hold, we start the time based on when they were detained by law enforcement or the crisis commission.
Oh,
If they're voluntary, we start the time based on when we confirm that for them, we place them on hold.
right. When I was much younger, you would go to Center Davis and they would have somebody diagnose you, right? And then you would be sent to 3B North. And then we got to 3B North, they're 5150. But my other question is, so can you spend a whole 5150 at Center Davis?
It is possible, because the 5150 is the 72-hour
Right.
detainment time. So it is possible that, you know, hey,
That's-
somebody placed on the 5150 is referred out for placement in hospital. Now, the inpatient hospital doesn't have beds, or they're not going to, they can't accommodate this patient because of what their needs are at that time, then they will remain in the hospital. Right?
Well, that's great.
And we reevaluate every day, so we don't just place you on a 5150 and say, here, you're gonna sit here for 3 days if you go.
So you used to.
We reassess within every 24 hours. So if I saw you at 9 a.m. on Wednesday, by 9 a.m. on Thursday, I'm giving you another assessment, because we assess each day to determine if it's still appropriate for you to meet criteria. You might come in Monday, and by Tuesday night, you don't meet criteria, or by Wednesday, you clear it up, or we have more understanding and you get appropriate discharge plan. So just because you start off on a 5150 doesn't mean you need to stay there.
Well, that's great. And that's why I asked about the 3B North, because I was thinking, you have all these people at Center just waiting for the 3B North, which is a very small mental. But that's awesome that they're doing that now and you're part of it. That's great news.
Last question, Brad. Yeah.
Okay, go. That's fine. I'm really impressed with that. That's all.
All right. So Meg has a quick question.
Just thank you. It's very gracious to guys. Knowledge. So I guess the question is, what do you, if there was one thing you could ask of us, or you wanted to know, one thing to consider, you don't have to tell us now, or you can let us know, but I think you would all probably want. How can we support you? What is that?
What is something we can do at our hospital on our end that would be of most perspective? Like more the idea that we can do, for instance, our hospital that would be more service.
Speaking for myself, not need my administrators. continue to support the co-responder model and have the alternate options available to people so that it has benefited our responses immensely. It's a non-siloed response. And I would say continue to support that, support its development and of law enforcement, but also everybody.
I think part of it is learning what the community needs are. I mean, part of that is, and not a self-serving way, but the community has said that they would like more co-responders. Because there are a lot of people that in need, and it's hard to meet everybody's needs at the time that we have. So I think it's just listening to what the community says. And part of the, also the CIP model is to reach out and engage the community and the different providers. We are looking at reaching out to fire. Fire's always wanting to know, and do better than you guys. And then also we had Cash Creek reach out to us and want training. And I think that, with the CIT, it's limitless because part of that is that you can do CIT for the citizens, for the community, and teaching them more so about some of the things that law enforcement, like you learned here today, there are certain limitations that you guys have to abide by. And the general population doesn't understand.
That would be great with the Citizens Academy, which is what we do with DA's office. Great. Okay, before we move to public comment, any other questions? All right, so we're going to go a little late today. I'm sorry, we started a little bit late due to the technical difficulties, which were out of our control. Christina was scurrying to get everything done when we had problems, so I appreciate that. So we're going to go to public comment. I know that Christy wanted to make a public comment. Welcome back from San Diego.
Well, I'm still here, but yeah, thank you. I'll try to keep it brief, but I have something here I prepared, so bear with me. Let's see. Okay. I think the biggest point I just want everyone to kind of absorb is that, the emphasis that it's important to incorporate the consumer and family members' feedback within the 5150 system, that we need to humanize the process more and realize that people who are undergoing this process, the 5150s, aren't someone else, that they are, our family members, there are children, they're members of our local community, and, there are friends, our coworkers, and too often people who have a mental health issue are othered and dehumanized. And ideally, the system that they would have to encounter, you would think it would be obvious that they would recognize that this vulnerability, but too often they are treated like others. And I have a quote from an NPR interview where Ellen Sachs, who's a professor of law who lives with schizophrenia, was encountering her law professor, and she was commenting on her notes on a journal on mechanical restraints. And she consulted her law professor, who was also a psychiatrist, and thought surely that he would agree that restraints must be degrading, painful, and frightening. And he looked at her and in a knowing way said, you don't really understand. These people are psychotic. They're different from us. They're different from you and me. They wouldn't experience restraints as we would. And she didn't have the courage to tell him in that moment that, no, we're not different. We don't like being strapped down to a bed and left to suffer for hours any more than anyone would. In fact, until very recently, I'm sure some people still hold it in a view that restraints help psychiatric patients to feel safe, but she had never met a psychiatric patient who agreed with that view. So I just want to shed some light on this whole process, is that yes, it's necessary and it's life-saving, but in these situations, there's a vulnerability that requires looking at the how the process is done and remembering that, the stigma and the dehumanization of the process can gravely affect the outcomes. And if these patients are treated with kindness and respect, it can drastically influence the quality of care. And, treating someone with gentle, kind words can help them be more receptive to their healthcare process. So when a 5150 or any form of restricted treatment must occur, it's essential to treat the individual experiencing it with compassion, dignity, and respect. A person-centered, compassionate approach is a non-negotiable aspect of the mental health treatment system. I hope that existing systems of care will be receptive to this consumer feedback. Thank you all for your time.
Thank you, Christy. Any other public comment, either in the room or virtually? All right. Well, thank you very much for your time on a Wednesday evening. We really appreciate it. This is very, very valuable for us. I love the idea of the Citizens Academy, the CIT. And so thank you. We really appreciate it. Thank you. Okay, we're going to move. Yes.
I just want to thank you all too very much. And just around the 5150, I think you were going to ask me, Carly, and I didn't ask you my question. Just the one thing I wanted to add is that for clinicians or just folks out in our community, in order to be certified to write a 5150, they have to be authorized by the mental health director to then receive the training and certification to be certified to write a 5150. And I want you all to know that we take that authority very seriously in Noel County. And I would say that we actually get some flack from the community about sort of gatekeeping that authority and limiting the number of folks who are certified to write 5150s in the county. But to all the points that Christy just made, we're talking about taking away people's rights, right? And we want to ensure that that the folks who are certified to write 5150s, and this is outside of law enforcement, right? So I'm talking about clinicians and medical, providers in the community. And so I just wanted this group to know, I'm not sure how much folks are aware of that, but that's under their authority of the appointed mental health director in the county. And they go through a formalized training that we contract for, but then there's local training that Rob facilitates. And so that is all a really important process to us locally. And we consistently review that list to make sure, do all of these people still need to be certified to write 5150s? And it's something that we just take very seriously, that level of responsibility. So I just wanted to share that. And thank you all again.
Thanks. Mental health director's report, that we have 3 items. Anyone want to pull any one of those 3 items? A, B, or C? Okay. Yeah, I know. Anything you want to share, Carly, yourself?
No, I mean, just that there's quite a bit of data in here about the mobile pricing, the medical mobile price benefit. And I know that our previous updates have been more general. And so I just encourage you to look over the data to review the report. There's also, I think, a bit more concrete updates here around our implementation of the high-tech call center, including the data that they're able to track and that they are tracking around the timelines for the first set of outcomes and deliverables that we'll get from our provider. So I would just encourage folks to review that if you're interested.
Thank you. Okay, criminal justice update.
We do have another mental health version graduation on June 12th at 10 a.m. We have 3 graduates. I do not know if it's going to be very interested in attending that. Please contact me. I'll be contacting people. So Joe reached out to me and couldn't find my phone number on your the board thing. I was wondering, and I don't know if I should be talking to Christina or whoever, but can we get a new person with needs to know line? I don't know. I would not know how to contact Chris at all.
Yeah, we'll get that. Christina, can we get?
Send it right now.
I'm sorry. I hope I'm not being rude.
You're not being rude at all. It's a great idea. Okay. We don't have board of supervisors report. Let's go to the member announcements. Any member announcements? Okay, no member announcements. So we have 2 items which we could delay. We have the bylaws approval. I don't know if anyone approved the bylaws. We want to do that. I don't think it'll take long, and I know that Sue or Chris can briefly tell you what it is we changed, and then we can vote. If that's what the board would like. No, we want to delay it.
Well, we're gonna vote.
Oh, you didn't read it?
Well, the edited version.
Yeah, I think it was.
It didn't have a red. Oh, yeah.
Okay, so in any event, thought it was provided, but we'll pass it.
I did. I also left a copy on the counter there too.
Oh, okay.
So basically, so do you want to, I mean, whatever any person wants to do, you want time to review it? Do you? We have time.
Reviewed the version online, so I don't think there's a substantive, but I didn't see the copy on.
So all we did,
I think in general, we eliminated based on the last meeting, we got rid of the standing committee. And we also got rid of the executive board, and that contained the officers. We didn't seem to get a need for the executive board for the bylaws. So it's kind of a big thing.
and we'll do another amendment for January of,
Service across the way.
yeah.
Well, no, I mean, I agree that this is a pretty small group at that. I'm just wondering if there's ever a time when the mental health director needs to get.
So can I explain that? So I'm sorry to interrupt you, but we took that off because we didn't want it to be a standing committee that every time that committee met, which we, we
Right.
have to comply with the Brown Act.
Right.
But we can do it ad hoc. So it doesn't mean we can't, do it ad hoc, but if we had it listed so explicitly, then we felt it would have to do.
That made sense, but that's not what Chris.
Yeah,
Well, I thought we limit them.
yeah, that's what happened. So if anyone here, and please
Thanks,
speak up, if anyone here needs more time to review it before we vote, we can totally delay this. But if we want to get it done with, and we think we can do it quickly, that's fine.
The executive committee also had chairs from the standing committee on it also.
Yeah.
When there was a standing committee, we didn't have that number.
Okay, so do we want to vote on this today, or do we want to put it off?
Didn't we also say that we could change it later if we want to?
We can always change it.
Yeah.
Yeah, it takes a two-thirds vote. So do we want to vote on this now, or do we want to delay it? We can delay it.
I think we should do it.
Okay, let's delay it. Totally fine.
I only because I want to make sure.
Yeah, that's totally fine. Yeah.
I'm just gonna send out a copy of the new bylaws and a copy of the ones that this is right now, so everyone can see the changes.
Both.
I think that might be okay.
When did the new officers start? When's the?
July 1st.
Oh, so we should do that.
Fiscal year, yeah.
Okay. So, officers, Joe.
Yes. All right, so I was asked to head the ad hoc committee again, in trouble communicating with folks. I ended up talking to the folks that were also, everybody here, the only one I didn't get through to is I like the right email in front of them.
You did, I was out of the sense, not out of the sense, I was in July,
Right.
and
I wouldn't call it that either.
and the time, and the times didn't match up at all. When
Okay,
people
no
were
worries.
up doing stuff here.
So, really what it comes down to is there are folks that are gonna show interest down the road, but, right now we have the existing board members, are all graciously volunteering to put together spots and all these.
Okay, so I heard what you said, people will be interested in the future, so I expect to have people interested.
I made those, I'm gonna send them to you.
Good. Okay, so, then we'll vote on keeping,
There's one idea on this is that maybe we ought to have the vice chair moving to the chair, so it's kind of a movement at some point in the future, kind of as opposed to turnover of officers.
That's pretty much what historically has happened. You know,
There's may.
COVID and a bunch of other things made it hard.
yeah.
At this point,
Yeah, I expect that next year Maria will be. board chair. Yeah, all right, so, all in favor of keeping the officers as is, say aye.
Aye.
All opposed? Abstentions? Okay, all right, so that, we're done with that. I want to go back to our board of supervisors report, see if Sheila has anything she wants to share.
Hi, I'm Sheila Allen, the current deputy to supervisor for Venza, District 4. I'm also a supervisor elect. I will be the supervisor for. It is budget season at the Board of Supervisors, so we are looking at the funds that come for mental health services and other support services that would be of interest to this group come from the federal government, which in some ways budgets are reliable because they can't seem to ever change anything they're getting through. But state is a little more in flux and on the downside these days. So we're watching carefully to see how everything looks to try to for this year hold as is. We will see how that result that they revised came out with that. We'll be having a budget hearing hopefully tomorrow. I don't know, soon. So this group might want to look specifically or hear from the director about what financial impacts there will be. There's a lot of power out throughout Yolo County right now, by the way. Electricity and some other places, and just if you know some people that it's very hot. That so it's not so clearly are unhoused. We'll have access to water and cooling, but also people who don't have electricity need a place to go. You know, in Davis, there seems longer, and the firefighters are out giving out water. So be mindful of your neighbors if you have power and they don't. I think what else is related to this thing? I think we have a new library being built in Davis that will be a place for meetings. If you ever want to have some meetings in South Davis, that will be available to you. It's also going to be, we're not talking about this a lot in the community because there seems to be confusion about it, but it will be a resilience center, not a homeless shelter, but a resilience center in that an event like today, that it will have battery, solar and battery backup. So if everything, all electricity is up, people who need to have cooling or heat or access to electricity, like for their oxygen, or to be able to charge their cell phone, have access to that. So that's okay.
Okay.
Just an opportunity with an audience here. As a group here, we're very concerned about funding for the public guardian and lack of
Yes.
overwork.
Yeah.
Lack of resources for that. Wanted to point that out since you're here.
Yeah, we had an individual supervisors and their staff received some presentations, and then there is a request in the budget process now to add some positions. Also, the And there's a ad hoc committee for the board of supervisors looking at, aging and, persons with disability, and they also have a presentation. So, we are aware. Yeah, yes. So it is.
Change and all that.
Right.
Requires more funding.
Yes, exactly. We're looking at like where, well, it's all general fund. So that's the hard part is we have a very small general fund compared to just about everybody else in California. So we don't have a lot of flexibility in there, but we hear the priority and also the growing need, because there's going to be more older adults and there's more need. There's a current need and then it's a growing need. So thank you.
All right, is there any public comment? I think we only have one or two online. Seeing none. Thank you, Christina. I know that was kind of an anxious time, causing stress. And thank you, Carlene, everyone else, and staff, for doing all you're doing, your presence, and Sheila for joining us today. And sorry we had to stay late, but we made it in 2 hours, less than 2 hours. Thank you.
Thank you, Christina.
Sorry. Sorry. Sorry.
And
Busy day.
you can announce it, but you're not.
Yes.
All right.
Yeah. July, yeah. We're not meeting in July. We're meeting in August. Yeah. I know.
Yeah, you are. I remember.